Beginning of head transplantation and vessel anastomosis. Ever since the early 19th, people have discussed the possibility of head transplantation. However, the transplantation surgery at that time faced many challenges. One of the main challenges in transplant surgery was reliable vessel anastomosis. The challenge faced by vascular surgeons was how to cut and repair an injured vessel and subsequently restore blood flow without interrupting circulation. Bone, silver and gold, and absorbable material grafts were in use in the early 19th, but these materials gave uncertain and variable results in patients. It was French surgeon Dr. Alexis Carrel who changed these results by using a more reliable method of suturing severed vessels back together. He used fine needles and extremely thin threads as suture and enlarged the severed vessel opening using three retaining sutures to form a triangular shape. His method proved effective in protecting against postoperative hemorrhages and embolisms, as well as in preventing strictures at the site of suture. Carroll was able to successfully implement this technique to vessel reconstruction and whole organ transplantation, mainly in procedures involving the thyroid and kidney. In 1908, Carroll and American physiologist Dr. Charles Guthrie performed the first dog head transplantation. They attached one dog's head onto another dog's neck, connecting arteries in such a way that blood flowed first to the decapitated head and then to the recipient head. The decapitated head was without blood flow for about 20 minutes, and while the dog demonstrated aerial, visual, and cutaneous reflex movements early after the procedure, its condition soon deteriorated and it was euthanized after a few hours. While their work in head transplantation wasn't particularly successful, Carroll and Guthrie made significant contributions to the transplant field's understanding of vessel anastomosis. In 1912, they were awarded the Nobel Prize in Physiology and Medicine for their work on limb and organ transplantation. Another milestone in the history of head transplantation was reached in the 1950s due to the work of Soviet scientist and surgeon Dr. Vladimir Demikov. Like his predecessors, Carroll and Guthrie, Demikov made notable contributions to the field of transplant surgery, especially thoracic surgery. He improved upon the methods available at the time for maintaining vascular supply during organ transplantation and was able to perform the first successful coronary bypass surgery in dogs in 1953. Four dogs survived for more than 2 years after this surgery. In 1954, Demikov also attempted a canine head transplant. Demikov's dog demonstrated more functional capacity than Guthrie and Carroll's dogs and were able to move, see, and lap up better. A step-by-step documentation of Demikov's protocol published in 1959 reveals how his team carefully preserved the blood supply to the lung and hearts of the donor dog. First, they made an incision at the base of the large dog's neck, exposing the jugular vein, the aorta, and a segment of the spinal column. Next, they drilled two holes through the bony part of one vertebra and threaded two plastic strings, one red and one white, through each of the holes. Then, he and Demikov deftly wielded the scalpel, needle, and thread, proceeded with infinite pains to expose the small blood vessels, drawing a tight knot of thread around each one in turn as they carved gradually deeper into Shauka's vital. Finally, Demikov severed the spinal column. Thus, even though the rest of its body had been amputated from this dog, its head and forepaws still retained and used the lungs and heart. During the third phase of the transplantation, the main blood vessels of this dog's head were connected with the corresponding vessels of the host dog. The longest that any dog survived this surgery was 29 days, also longer than Guthrie's and Carroll's dog, but most died within a few days. This limited survival was mainly due to an immune response of the recipient to the donor, and the next major challenge of heart transplantation involved the lack of immunosuppressive agents available at the time. Without effective ways to manage the immune rejection reactions between the donor and recipient, Demikovs couldn't be considered in the clinical realm for use in humans. The issue of immunosuppression will be addressed below. In 1965, Robert White, an American neurosurgeon, also attempted head transplantation. His goal was to perform a brain transplant onto an isolated body, contrary to Guthrie and Demikov, who transplanted the entire upper body of a dog, and not just the isolated brain. This required him to establish different perfusion techniques than his predecessors. In fact, maintaining blood flow to an isolated brain was the biggest challenge for White. He created vascular loops to preserve anastomosis between the internal maxillary and internal carotid arteries of the donor dog. This system was referred to as autoperfusion, in that it allowed for the brain to be perfused by its own carotid system even after being severed at the second cervical vertebral body. Next, the brain was positioned between the jugular vein and carotid artery of the recipient. Using these perfusion methods, White was able to successfully graft 6 canine brains to the cervical vasculature of 6 large recipient dogs. The dogs survived between 6 hours and 2 days. By continuous electroencephalogram (EEG) monitoring, White monitored the viability of the transplanted cerebral tissue and compared the activity of the transplant brain to the recipient brain. Moreover, using an implantable recording module, he also kept track of the metabolic state of the brains via measurements of oxygen and glucose consumption, and demonstrated that the transplanted brains were in a high-performance metabolic state after surgery, another indication of functional success of the transplants. Through his autoperfusion protocol and subsequent tracking of brain function, White demonstrated the short-term feasibility of a pure brain as opposed to upper body transplant. White expressed an interest in using these methods to develop a model system whereby he could induce tumor formation, meningitis, or encephalitis in the brain being transplanted and subsequently test whether the normal recipient animal's circulating blood could restore functionality to injured brains. In 1970, White performed the first cephalic exchange transplantation in primates. He performed 4 cephalosomatic associations between isolated monkey heads and isolated monkey bodies, employing direct suture of the carotid and jugular veins. Cervical laminectomy was performed at the level of the 4th through 6th cerebellar vertebrae. Due to the subsequent spinal shock and hypotension following transection, catecholamine infusion was started and mechanical pulmonary support initiated and maintained throughout the remainder of the experiment. 3 to 4 hours after surgery, each cephalon was able to chew, swallow food, track with eyes, and bite if orally stimulated. Moreover, through the EEG monitoring, White demonstrated that these cephalons exhibited a characteristic awake pattern. Despite the aforementioned advances, revascularization in the cephalon remained a challenge and survival ranged between 6 and 36 hours. Due to constriction that developed in the jugular vein at the suture line, venous return from the head was embedded. The direct suture was, therefore, not successful enough to allow for unimpeded blood flow, and the cephalons required continuous infusion with heparin. This eventually led to blood loss and was a limiting factor in the longevity of this experiment. Moreover, White acknowledged that the cervical spine transection was another limitation of his methods, as it necessitated the implementation of continuous respiratory support for the animal. Spinal transection and cephalon revascularization and ischemia will be addressed below. Further modification of optimal vessel anastomosis occurred years later in 2015 by the Chinese surgeon Xiaoping Ran. In contrast to the previously described direct anastomosis, he utilized a method in which only one carotid artery and the contralateral jugular vein were cut, allowing intact carotid artery and jugular vein continuously perfores the donor head throughout the procedure. Using this protocol for head-body transplants in mice, he was able to maintain the blood pressure of mice above 100 divided by 60 millimeters mercury during the entire procedure. Moreover, EEG recordings from both donor and recipient heads after surgery demonstrated normal electrical activity. By cutting only one carotid and jugular vessel, Brand's method minimized trauma to the recipient, prevented development of ischemia, and also allowed for intact brain function. Over half of his mice survived for periods longer than 24 hours, with the longest survival being 6 months, while white stock and primate head transplants had demonstrated short-term success, in part due to complications related to clotting, heparinization, and ischemia. Rand's revascularization protocol allowed for longer term survival in mice.